Welcome to this episode of the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. In today's episode, we will be highlighting an optometry and vision science publication from last summer that we missed during our hiatus. This paper I'm referring to is Summers et al.'s pilot randomized clinical trial of base-in relieving prism spectacle treatment of intermittent exotropia. My name is Plauman, and I have invited Angie Chen back to round out this series of podcasts looking at different treatments for intermittent exotropia, or IXT. Angie is a diplomate in the binocular vision, perception, and pediatric optometry section of the Academy, and one of the authors of the writing committee for this paper. Thanks for joining me once again, Angie.
Thank you for having me again.
Anytime. So in today's podcast, we're tackling another PDIG IXT study. So can you provide some insider information on what motivated this study for PDIG?
Yeah, definitely. So PDIG has a bunch of study looking at treatment effectiveness for childhood IXT. And then when you look at our treatment options, Base and Prism is one of the treatment options. But when you dive into literature, you'll see that there's very limited literature on Base and Prism as a sole treatment for childhood IXT. So that's really the whole reason why they want to do a clinical trial looking at Base and Prism. But it's quite dangerous to jump into a large clinical trial. And that's why this study is a pilot randomized clinical trial of relieving Base and Prism for childhood IXT. So they really want to just see, what's the short-term effect of Base and Prism in improving distance control. And also the information from the pilot study will let us know whether the study is feasible. Can we recruit patient? Can we retain patient? Will the patient wear the glasses because they are going to be on the heavier side? And so those are all the things that we can gather from doing a pilot study. And based on the results of the pilot study, then we can decide whether we want to proceed to a full clinical trial or not. So in the study, if you look at the paper, there are actually criteria that they use to decide whether they will proceed to a full clinical trial or they would not.
Okay, and since we're talking about IXT, I'm assuming the outcome measure was that office control score scale. And I just mentioned this now for any listeners out there who still have questions about the control score. I recommend you listen to last month's podcast where we covered that when we talked about Ma et al.'s vision therapy paper for IXT. So Angie, can you provide us with more details on the children enrolled in this present study that PDIG conducted?
For sure. So in this study, we enrolled children who are 3 to less than 13 years of age with IXT. We use the IXT control score. And so during the enrollment visit, we measure it 3 times, and then we take the mean of the 3 measurement. It has to be 2 or worse at distance with the at least 1 spontaneous exotropia. So we're definitely looking for children who don't have well-controlled IXT. The magnitude of the deviation was between 16 to 35 prism diopter. I do want to point out something that's really interesting. I think a lot of practitioners, they don't want to prescribe prism for these children because they worry about children adapting to prism. Mm-hmm. And so in the study, we also do a test called Prism Adaptation Test. Basically, we want to see if these children adapt to the prism. And if they show full adaptation after 30 minutes of wearing the prism, then they are actually excluded from being randomized to either Base and Prism or non-prism glasses.
Right. So there was kids wearing the prism glasses and then kids wearing, I'm assuming, Plano or whatever their prescription was. Mm-hmm. Okay. Mm-hmm. So then again, when you bring up what practitioners do about prism, how did you go about determining what amount of prism a participant would get? And then you mentioned about, curious on the tolerability, shall we say, of the glasses. Mm-hmm. Do we have information on how the glasses were worn by the 2 groups?
Mm-hmm. Yeah. And so obviously there are a lot of ways to prescribe prism. We had to standardize it. So in this particular pilot study, we were prescribing prism in the amount that's 40% of the larger deviation between distance and near. So let's say if the larger deviation is 20 prism diopter, then 40% of the 20 prism diopter will be 8 Base and Prism. Mm-hmm. So it's going to be 8 Base and split between the 2 eyes, so 4 and 4 in each eye. So in the study, the magnitude of the basin prism ranged from as low as 6 prism diopter to as high as 14 prism diopter. In terms of how well these children wore their prism glasses, based on parental report, it was reported as excellent in 88% of the participants. So meaning that for most of the kids, they were wearing their glasses without any issue.
Which is great. And they didn't know which group they were in, right? The Prism or the non-Prism. So this is the overall
right.
clients one?
Yeah. Parents and kids, they can always guess, but yes, they don't know. Yeah.
Yeah. Okay. So we know they were wearing the glasses. Well, most of them anyway. What did PDIG find out from this pilot? What were the results?
Yeah, so this is a pilot study. So the primary outcome was at 8 weeks. So it's a pretty relatively short prism wear time. And then they found there's a small difference in control score at 8 weeks that actually favored the non-prism spectacle group. Yeah, and so because of that, it didn't meet it met the do not proceed criteria, meaning that they're not doing a full clinical trial.
So maybe a little disappointing for our fans of Prism out there. And obviously it's pilot and there's this set, rules. So the 40%, maybe there's another magical number out there. So I'm just speculating, but I'm curious for your, impression of this and kind of your takeaway. How do these findings influence your clinical practice? And in your opinion, what's the role of Basin Prism for childhood IXT, or what do we need to do next?
Yeah, I will be honest. I'm not a big Prism prescriber when it comes to managing childhood IXT. I've done it a few times. I typically go to Prism, if I got a patient who's got esotropia or if it's an adult patient. But usually, childhood IXT, I do over minus lenses. I do vision therapy. Sometimes I monitor if the kids are really young and the control is not too poor. One thing I would say is it's missing. It's the child's sensory fusion status, because when you think about prescribing Prism in clinic, I typically would prescribe Prism for those who respond to Prism, right? And so if I trial frame Prism and the Prism establish or improve sensory fusion, and then that gives me confirmation that this is a patient who should respond to Prism, overall pretty well. Or if when it comes to IXT, I want to see if the Prism actually improved their control. And so typically in clinical practice, I would trial frame it and I would tweak the Prism, so if I start with 40% as my starting rule, I may increase it, I may decrease it, just depending on how my patient respond, but you can't really do that in a clinical trial. Everything has to be standardized. I totally understand that. But I think when it comes to prescribing Prism, there's more we need to look into, when it comes to the patient sensory fusion and then figuring out whether they are good candidate for Prism. But I did learn something from this clinical trial, because what they observe is when they saw some of these patients at 8 week, even though they didn't adapt to the Prism initially, 24% of these patients show full Prism adaptation at 8 weeks. And I was actually really surprised by this finding, because to me, the patient who would Prism adapt are those who have constant strabismus, they have poor sensory fusion, like deep suppression or anomalous correspondence, but it's not these patients. So potentially, maybe we just didn't uncover the full amount of exo deviation until at 8 week. And so if I were to prescribe Prism again, for these patients, I probably need to consider doing Prism adaptation tests to make sure that I have the best candidate in the chair before I make them buy a pair of glasses. So that's certainly a lesson that I learned from this clinical trial.
No, it's very intriguing. It has me thinking about my patients too, or patch them a little longer while doing cover tests to make sure you're really uncovering the whole exo. Fascinating. Well, thank you so much for joining us again today and teaching us a little bit more about what we know out there on Prism treatment for childhood IXT. And we'll see you around the academy.
Thank you.